I'm Laura Jacques. I think I know most of you who are here and also here. Thank you for joining us this morning. We have a very exciting special edition of Badger Bytes this morning. Badger Bytes, as you all know, is our talk where we have a couple different researchers who work in areas that are similar and have some overlap, present their work to stimulate conversations and ideas and let everybody know all of the exciting things that's going on in our department. And this particular edition is focusing on some of the work that has been done over the summer with our medical students who are participating in the Shapiro program. So I'm going to go away from the Grand Rounds text message, but I think it goes in the chat and you can all text each other for it later too, as I know also happens. Not that I would ever do that, but okay, how do I advance? Nope, I got it. Okay. All right. So the Shapiro program is run by the medical school, and this is a either 8 or 10-week program where medical students in between phase 1 and phase 2 can work with a faculty researcher on a small curated project. And the program has been going on for quite a while. Our department has often had robust participation. We usually have anywhere from like 4 to 8 medical students who are rotating with our department for the summer. This summer, we had 5 students. And those students are going to present their work to you today. We are doing this partly to showcase the great work that they've been doing and also to highlight the program so that if anybody is interested going forward in having some help with their research, then they should go ahead and submit to the medical school a proposal by January. So you can submit anytime. There's a website run by SMPH where you fill out like a Google form that describes what your project is and how you might see a medical student being involved in that project. And then that gets put into a database. So when the students in February start looking for projects, they look and see if that would fit their interests, and then they would reach out to you. And then there's kind of an interview process where they interview you and you interview them and see if it would be a good fit. The students today are presenting in a format that is called the 3-minute thesis. So this is like a national program where grad students and postgraduate students present their work using 1 slide and only 3 minutes. We have slightly tailored that. We've allowed our students to use up to 3 slides if they want, but they're still going to stick to the general 3-minute format. And then we're going to open it up to questions afterwards. And my colleague, the good Dr. Pennycuff, is here to MC that portion. And after they present, then we'll open it up to questions from you guys. So I'll turn it over to Dr. Pennycuff.
Thank you, Dr. Jacques. I know I was not late. We're also going to follow a format like the Society for Gynecologic Surgeons does. So what we're going to do is the student will present. And then the moderators will ask me. We'll ask a question that is tailored to their presentation appropriately for their level. And then we'll also open it up to the audience. Okay, so our first presenter is going to be Sammy Stroebel. She will be presenting on obstructive sleep apnea and time to pregnancy. And her mentors are Dr. Laura Cooney and Dr. Ankitha Maddy.
Good morning, everyone. So as you may know, obstructive sleep apnea is a common condition in which the upper airway repeatedly collapses, leading to numerous awakenings and sometimes oxygen desaturation. It's estimated that around 9% of pregnant people have sleep apnea, and this percentage increases in high-risk pregnancies. Sleep disturbances during pregnancy, including undiagnosed breathing disturbances and diagnosed sleep apnea, are associated with complications like gestational hypertension, gestational diabetes, preterm birth, and preeclampsia. However, there are not studies that evaluate the impact of OSA on infertility and time to pregnancy, and so we designed the following study. Patients establishing care at Generations Fertility Clinic completed questionnaires to screen for sleep apnea, depression, and anxiety, and then we compared patients who screened positive and negative for OSA looking at odds of ongoing pregnancy. So at the time of this presentation, we have demographic data on 218 subjects. 11% of subjects screened positive for sleep apnea. Those who screened positive had a higher BMI and a higher prevalence of hypertension and type 2 diabetes than those that screened negative. 5% of patients screened positive for depression, and median PHQ-2 scores were higher in those at risk for OSA, but the percentage of subjects that screened positive was the same in each group. Both median anxiety scores and prevalence of mild, moderate, and severe anxiety were higher in those who screened positive for sleep apnea. So we've organized that here by all patients not at risk, at risk. And then you can see that a good number of the p-values are statistically significant. So we've finished collection of pregnancy outcomes at this point for 175 of our subjects. They were followed for a median of 15 months, and 50% of all patients achieved a pregnancy during that time. Patients who screened positive for OSA had a lower chance of achieving an ongoing pregnancy and/or live birth. However, after adjusting for BMI, this association was no longer significant. We found that for each increase in BMI point, there's a decrease in the odds of ongoing pregnancy, suggesting that BMI is the primary driver of these outcomes. And we'll use this to continue to inform our data collection and analysis going forward. In the coming months, we plan to continue data collection as well as analyze time to pregnancy, pregnancy outcomes like miscarriage, and then the IVF details that we've collected. Thank you for your time.
Can you advance the slide?
Mhm.
Can you advance one slide?
Yes.
Okay, so Sammy, given the findings of your project, would you screen everyone for OSA who's trying to achieve pregnancy? If yes, why? If not, who would you screen?
I don't think that, I think screening everyone for OSA would be helpful, especially since stop bang is something that's fairly accessible, inexpensive, and quick to do. But I think in particular, focusing on patients with other comorbidities would probably be the most efficient.
Excellent. Any questions from the audience? It was so good, you left us speechless. Thank you.
Thank you.
Oh, Dr. Hartenbach.
Others may know this, but is obesity an independent predictor of poor fertility outcomes?
I think the answer is yes. There's a lot of
And
head nods.
is someone in the audience can inform me and others about that? Do we have some expertise?
Hi, this is Laura Cooney. Just a plug for the Shapiro program. Sammy's amazing. I've had multiple students work with us. Yes, BMI is a major predictor, both looking for patients who aren't necessarily infertile, but are interested in trying to conceive, looking at that sort of initial time to pregnancy. It's a predictor in patients who are doing ovulation induction, and a major predictor in outcomes for IVF as well.
Any other questions? All right. Sammy, thank you so much. That was wonderful.
Thank you, Dr.
All
Cooney.
right. Did we move the video? Get moved? We moved. Okay, we'll come back. That's not a problem. No, that's wonderful. All right. Our next presenter will be Amy Tran. She will be discussing pelvic floor symptom burden and treatment choices for rural versus urban dwelling women. And her mentor is Dr. John Pennycuff. That's me.
Good morning, everyone. So again, my name is Amy Tran, and I'm working with Dr. Pennycuff and Dr. Christina Warner. And our project is on the pelvic floor symptom burden and treatment choices for rural versus urban dwelling women. So historically, people living in rural areas have been shown to have health disparities compared to those living in urban environments. And this includes gynecological health disparities as well. And in Wisconsin, 46 out of 72 counties are considered rural and make up 30% of Wisconsin's total population. So it's a really relevant study for our state. And we are distinguishing rural versus urban using the DHS county designations, the RUTA score, which compares rural disadvantage versus advantage and urban disadvantage versus advantage, since we all know that all rural areas are not built the same and all urban areas are not experiencing the same resources or lack of resources. And lastly, we're also using the area deprivation index. And in this figure, I just wanted to show that these are some of the factors that may affect healthcare access in rural areas. So lack of health education, health insurance, health screenings, or lack of health screenings, and also the distance traveled to clinics. So we have two objectives for our project. The first is to compare pelvic floor symptoms among rural and urban dwelling patients. And the second objective is to compare the treatment options chosen by rural and urban dwelling patients. And this is to compare whether they are choosing more invasive options or conservative options. So for our study design, I'm sorry, our slide got a little messed up, but the first is to identify the patients who fit our inclusion criteria. So for the data that we were able to extract, we decided that we're going to use new patient visits at the Advanced Pelvic Surgery Clinic between January 2020 and December 2022, which is about 2,000 patients. Although we are talking about also including patients from 2019, but we'd have to manually extract some data for that. So we want to include that to also look at times before COVID. And currently we're on the collecting step where we're using retroactive chart review to extract the pelvic floor disability index, the area deprivation index, RUTA score, DHS county designation, distance travel, and the treatment plan. And after we extract all of that data, we're going to analyze it using a descriptive statistical analysis to compare the burden and also the treatment options. So currently we have not analyzed any data, so I don't have any preliminary data for you to look at, but this is the project that we're working on.
Wonderful, Amy. Thank you so much. Can you advance the slide for me? Okay. So let's say you find that women living in rural or underserved areas of Wisconsin have more severe symptoms. How would you use that information to improve care? Let's say you have unlimited lawmaking power and unlimited budget.
Okay, that is a great question, which might be beyond my role as a medical student. But so I think in the slide that I had earlier, I listed some things that may contribute to rural area and underserved areas having worse outcomes. So definitely, I think that we should have more clinics that help screen these patients to help them get healthcare at an earlier time rather than having it advanced before they traveled like all the way to Madison, like maybe more than 100 miles to get care. Yeah.
Wonderful. Thank you. Any questions from the audience?
Can I ask a question?
Of course you can.
So what is your hypothesis? What do you think that you'll find and why?
Yes. So since earlier I said that rural and not all rural areas are the same, like some areas such as Door County are more privileged areas. I think using the RUTA score, we can probably, we're hypothesizing that patients in rural areas, especially in rural underserved areas, they're going to have worse symptom burdens and also choose more invasive surgeries.
And a follow-up, why might they choose more invasive surgeries in rural areas with less access?
Yeah, so part of that reasoning is that because they have to travel so far, they might just want to like do an invasive surgery to kind of get it over with and try to do conservative treatments such as physical therapy, which they might have to come several times a week and have to travel long distances several times a week. Yeah.
Any other questions? Yes, Lindsey Christianson, I will bring you a microphone. Okay.
No, that's good. Get my steps in.
I'm just wondering why you all chose to include the year 2020 and like what you're thinking with the data there versus the years after, or if you have, just any thoughts on that.
So originally it was because of the data that we were able to extract easily, because a lot of the data before then wasn't inputted into the charts. That makes it easy to extract. And so in one of the further steps, we're also thinking about comparing, seeing if there is any difference between before COVID and after COVID. So we're definitely thinking beyond the scope of this project. Yeah.
Great. Thank you.
Any questions online before we move on to the next? Okay, I don't see any, but if you throw them on, we can ask them at the end. Thank you.
All right. Thank you. Okay. Our next presenter is Lindsey Christianson, who will be presenting information on following Dobbs decision OBGYN residency applicants. And her mentor is Dr. Laura Jacques.
And also Elise Cowley, who is in the audience here and is a PhD, MD PhD student.
Excellent.
All right. Cheer for Elise. All right. Thank you, everyone. Good morning. So in June of 2022, as you know, the Dobbs Supreme Court decision overturned federal protections for abortion. We evaluated how new abortion legislation and restrictions are impacting the real-time decision-making for applicants applying to OB/GYN residency programs. In order to understand one aspect of this question, we use the popular media site Reddit. For years, medical students have posted their experiences applying to residencies and interviewing to Google spreadsheets accessible via Reddit. In 2022, on the Google spreadsheet for OB/GYN residency applicants, a new tab was created to discuss the impacts of Dobbs on residency programs and applicants applying to them. We analyzed the Dobbs specific tab and other relevant tabs to research our question: how is the Dobbs ruling influencing decision-making for OB/GYN residency applicants? Our team of 3 researchers inductively analyzed 2,445 posts and found 4 themes, which I will present here. The first theme on the top right there is around surrounding transparency and clarity, with many posters expressing difficulty knowing what abortion training was offered at each program. For example, the applicant here comments that the program director was not comfortable discussing abortion training on their interview day. This lack of clarity means that applicants must search for answers through informal sources, such as interview day meet and greets and social media sites such as Reddit. The second theme below was that Dobbs led to increased uncertainty around abortion training in an already heterogeneous training landscape. Individuals often commented about the fluctuating guidelines following Dobbs, expressing frustration with unpredictable changes and lack of guaranteed training due to, quote, gray areas of abortion laws. The third theme here at the top right was that availability of abortion training impacts residency decision-making. Many applicants indicated that family planning was a top priority in their residency selection and would be dissuaded from ranking schools higher if they were informed that the training options would be limited there. The fourth and final theme was that applicants appreciate programs' support for abortion training. Even when programs had limited abortion training offerings due to restrictive state laws, applicants still viewed them favorably if there were program directors and faculty that were actively advocating for expansion of training at their site or partner sites. Overall, our research lends support to an increasing evidence base that the Dobbs decision is impacting how OB/GYN residency applicants determine where they seek training. Post-Dobbs, OB/GYN residency applicants are concerned about their ability to access family planning training and want programs to give them clear and accurate information about the abortion training they receive at that program. Thank you. Oh, yeah.
And
Questions for me.
apparently your question slide ran off. I don't know what happened, but good. Thank you. Okay. So the question that we have is, this paper comes out and it's published and it lands on the desk of every program and assistant program director in the country. How do you think that those individuals should use the information?
Yeah. Sort of as I was describing at the very end, but I think that program directors and their faculty, first of all, should be advocating for expansion of abortion training, but also just being very clear with their applicants as to what they're currently doing and the efforts that they're putting in to get training for them, even if it's not at their site. And I know that looks really complicated right now, and program directors are still trying to figure out what that means. But applicants on this Reddit platform were very confused about what the offerings would be. So I think just being very clear and honest so that they have that information going into their decision making.
Wonderful. Thank you. Any questions? I'm going to take Dr. Gravel.
What?
Then I'll come back.
I love this topic, so thank you.
I do too.
My question to you is, do you have a sense, it's impossible to know, of the selection bias of the group that you're pulling from, given that this is a very specific online platform, and how that might translate or how that might affect the way that you interpret your data?
Yeah, I think that since it's a social media platform, like that's definitely a limitation of this study, is that, people might be responding to other people with similar perspectives on the situation. So that is a limitation. But one thing that we do think the social media platform brings is unfiltered and real-time responses from applicants that they can submit like right after an interview or right after an interview day, so that we can get that information without say like interviewing them in person and perhaps having them filter their responses in a certain way. So yeah, thank you.
Wonderful. Dr. Hartenbach, I think you had a question.
Yeah, thanks for doing this. Obviously, a really important and timely topic. And we have a lot of media interest in, what's going on with residency applicants in the post-Dobbs situation. So thanks for doing this, and I hope you can get it published. My question is, did you in your study find people talking about Ryan programs at all? Is that something that's out there? It's all over Reddit. It's not all over Reddit, because I'm just interested in that. Obviously, I agree with you that program directors and chairs and everybody needs to be telling the applicants right up front what they know and what they don't know. Sometimes that's difficult, but that's what we needed to be doing and advocating, because abortion is essential health care.
Yeah, thank you for your question. We had many commenters commenting about whether a program was a Ryan program or not. Several of them talking about how that might be fluctuating depending on state laws, and also how programs are trying to get that new designation given the changes around the states around them. Yeah, so it's definitely something that's being discussed by applicants and being considered in their decisions as well.
Hi, Lindsey. Thanks so much for looking into this. I've been sort of doing my own independent mini research, if you will, as I prepare to apply for residencies in this upcoming cycle. So I've been taking all of this into consideration. And I was wondering if you found in your research, if there were differences in the way that applicants were approaching that initial application versus following up with an interview or in their rank list, especially with the recent addition of signaling, which really incentivizes applicants to be very selective in the programs that they apply to from the very beginning with that initial ARIS application. Did you find that people were focusing more on that first or that second part of the application process, or if that was different between them?
Yeah, thank you for your question. I think the study data that we have predates the new like stars or ranking that you're talking about for that first interview. But and also the data that we have isn't really analyzing like certain aspects of it. It's really just post-interview and their impressions of the program, and then how they're ranking or comparing programs after they've experienced speaking with the program itself. So sorry, I can't give more information to your question, but good luck.
Wonderful. Any other questions? Obviously, this is a hot topic for the medical students and all of us in the room, but thank you so much for your presentation. Our next presenter is Xiong, who will be presenting on optimizing care for patients with granulomatosis mastitis. Didn't know this existed until Dr. Bizzuto told me about it. So very excited for this. Dr. Laura Bizzuto is Duachi's mentor. Thank you.
Okay, so my name is Duachi, like Dr. John said. So this past summer, I worked with Dr. Bizzuto on a quality improvement project through the UW Cancer Center. We focused on patients with granulomatous mastitis. right, so the goal of this project was to assess whether patient experiences have improved after a clinical guidance was placed at UW in 2022, so last year. So before I go more into the project, I want to give you all a little bit background on what GM is and why we're focusing on this condition. So GM is a rare non-lactational inflammatory breast condition with no cure yet. The cause of GM is unknown. It doesn't seem to stem from any infectious sources. However, there is a subtype of GM called cystic neutrophilic granulomatous mastitis, or CNGM for short, that does grow a bacteria from the Corynebacterium genus when you culture it. So for this project, we're looking at both GM and CNGM patients. And then to confirm a diagnosis, it's done via a biopsy, and oftentimes once this is done, patients have already interacted with many different departments and have undergone many exams and procedures to come to this diagnosis. And so that all overall contributes to poor health or poor patient experiences. So this brings me back to the project. Right now, there's no recognized or standardized treatment nationally. And so last year, the UW Breast Clinic collaborated with multiple different departments and came up with a multidisciplinary clinical guidance with a purpose to streamline care for these patients. And so with this project, we are analyzing process-related outcomes such as potential duplicated visits, procedures, imaging, medication, labs, and more to see if this protocol has worked. So this brings me to my next slide with the methods. We are looking at patients with a time frame from May 1st, 2020 to May 31st, 2023, pre and post protocol. We were able to isolate 113 patients through UW HealthLink using the slicer dicer tool. And those patients included those diagnosed with GM, CNGM, and those undiagnosed but have similar symptoms. The information we collected included demographic data to see if there's any trends with race, insurance type, age, and sex. And then all the medical encounters that each patient had related to their breast condition. So dates of service or office visits, surgeries, ER visits, and then departments, imaging, labs done, medications, and stuff like that. So all of the information was stored in REDCap. So I just finished collecting data 2 weeks ago. Right now, we're still analyzing data, so I don't have any definitive results letting us know whether the protocol has been effective. However, I do have some raw data that's interesting. So right here, I have demographic data, specifically ethnicity, and I just want to show that with the, okay, well, so there's a total right here, and right here, there's 20 Hispanic patients.
That's a good. Okay.
So there's 20 Hispanic patients, and 9 of them were diagnosed with GM or CNGM. So that's 45% of Hispanic patients. And this is actually reflective of other literature in the United States showing the same trend. So it's just interesting that Madison also has the same trend. And then that's compared to 30.9 of non-Hispanics with a diagnosis. And then this is just an example of how we might analyze the data. Right here, I have 2 patients diagnosed with CNGM, one before the protocol was in place in gray, and the one after the protocol was in place in red. But yeah, so this is just interesting to see once you compare the 2 different patients. So the next steps, we will continue to analyze outcome measures such as the visits, imaging, biopsies, antibiotic use, all things that we kind of hope to see a decrease in after this protocol. And then the question right now is whether we should use a continuous or categorical method of analyzation, just because some patients were diagnosed before 2022, but then are still receiving care because this is a long, like, uncurable breast condition. That's self-limiting as well, so it resolves on its own. And then continue to use a QI methodology to look for trends, and then ultimately use this project to determine if the protocol worked or if there's changes that we need to make to improve patient care. And just acknowledgements, Shapiro program and Peter Meyer Burke Crystal Breast Cancer Research Award for funding the program. And then I want to thank Dr. Laura Bizzuto for mentoring me and allowing me to participate.
Okay. So a few slides back, you kind of showed patients before and after, and like that seems to be a way that you're considering analyzing data moving forward. And it seems that there was a decrease in healthcare utilization, number of visits, services that the patients required after the protocol. So that's a win for patients and it's a win for healthcare utilization, right? So how are you going to take this protocol that's very UW, like that's born in UW, how would you convince other healthcare systems that they should adopt this protocol?
That's a good question. Well, first, I think I want to do more analyzing to see if it actually worked or if it was just those two isolated situations. But I think I would just have to kind of present this information somewhere or share the information with other breast clinics or OBGYNs to show them that this protocol works. So.
Wonderful. Any questions from the audience? Dr. Hartenbach?
I have a similar, but, a related topic. So I guess I'm assuming that the primary thing you're looking at is decreased visits. Is that sort of like what you're thinking is if things are going to improve, it's going to decrease visits? Is that the main measure of improvement? Because that's what I'm interested in. What's your key measure of improvement?
Yeah, so we're looking at different measurements or outcomes. And so office visits are one of them. Hopefully that would increase once every department is on the same page of who's caring for this patient or where you would, like, for example, there's some patients who would go see infectious diseases if they have the CNGM diagnosis. And so like to streamline that care and then also to reduce the number of department visits. So if they don't need to go see a rheumatologist because they have a bacteria diagnosis, to see them first before utilizing other departments as well. So it's like office visits, departments, the number of lab orders, like do they really need to have repeated labs if a lab already has the information that you need? Yeah. And then like the amount of imaging done, the type of medication given. We're trying to reduce the use of antibiotic use just because if you have a GM diagnosis, you don't need antibiotics since there's no infectious sources. Yeah. And so we're using a lot of different measurements. Yeah. And they're all kind of, it seems like surrogates for improvement, because improvement would be decreased symptoms, improved health. So, if you don't have anything that's measuring that, you are making some assumption that less visits means it's improved. Right. But sometimes we increase copays, we make it hard for people to get in. They doesn't necessarily improve their health to have less visits. So, I don't know if there's any way you can measure an actual health improvement in this space, but that's great work. Thank you.
Any other questions?
We had a couple questions. One, would you mind just hitting, and I think you just hit a few of them, but what are like the key parts of the protocol that you've implemented that you're assessing? And then is there a patient facing survey or any information that you're gathering from the patients? Because a follow-up study could be doing some sort of interview or qualitative discussion with those patients. Since it's a relatively small number, you could get some good information that way.
So the first question was related to the protocol and how it works, correct? So for the protocol, it starts when the patient comes to the breast clinic, whether they're coming with like a breast abscess or other type of symptoms. And then from then on, you kind of, depending on which path or which type of symptoms they have, you either do a CNGM kind of protocol or a GM protocol, and they're a little bit different just in terms of the referrals. So that's how the protocol is being used. And then the second question, sorry, can you repeat the second question?
The second question was whether there's a patient-facing survey to get a sense of their symptoms, like Dr. was saying.
That's a good question. We don't have that yet. We didn't do that for this project. We're more so analyzing whether the protocol has changed or decreased patient interaction for now, but then that is a good follow-up research project to do.
Super cool project. Thank you for sharing with us. I have two questions. One is, does the 113 patients, does that match like the national prevalence? Like what you saw at UW, does that match the national prevalence for what you see for this condition? And then do you think that you're going to be statistically powered to tell if there's a difference pre and post protocol?
Yeah, so I'm not sure on the national level how many patients each like department or medical system has found in terms of diagnosis, but then it's generally a rare condition. There's not a lot of patients. And then the second question, that is, we're kind of analyzing that still and kind of determining how we're going to analyze and see if there's any statistical difference.
Yeah, really good job. Really good job presenting and answering all these really tough questions. Yeah. I would expect nothing less. So this was a quality improvement project, right? So we're not necessarily looking for like statistical significance. We're looking for like process improvement measures. And certainly next steps can be to look at a more like scientific analysis of this population. And but right now the focus was on the quality improvement measures.
Thank you. Great job.
Oh, I'm an elder millennial. I should be able to get the computer moving, but we'll see. Right. Okay. It worked last night on my laptop. Okay, why? We are experiencing technical difficulty.
Hello,
Oh,
my name is
we're-
Camille Phillips. I'm a medical student at UW SMPH. My co-authors are Dr. Jeanette Larson, Amy Godecker, and Dr. Laura Hanks. Together this summer, we analyzed sterilization trends for pregnancy-capable people before and after the Dobbs decision. Upon completion of this presentation, participants will be able to describe the impact of the Dobbs decision on sterilization trends at a single large institution in Wisconsin. On June 24, 2022, the Supreme Court decided Dobbs versus Jackson, which overturned Roe v. Wade and essentially banned abortions under most circumstances in Wisconsin. Anecdotal reports suggested an increase in sterilizations, but there is limited data to support this. So we hypothesize that sterilizations among pregnancy-capable patients have increased post-Dobbs, especially among younger and nulliparous patients. We conducted a retrospective chart review. We included all pregnancy-capable patients who were surgically sterilized from June 24, 2016 to June 23, 2023 at Meriter Hospital. We included all types of sterilizations, including tubal ligations and mostly bilateral salpinectomies. We used 2016 as a starting date to describe trends over the Trump administration and any disruptions during COVID-19. For our control, we determined our sterilization frequencies by dividing total sterilizations per year by the total gynecologic surgeries per year. We included patients ages 18 to 55 and excluded patients who were immediately postpartum or received their tubal at time of C-section. All statistical analysis was performed by Amy Godecker, and we used p-value of p less than 0.001 for statistical significance. This study was IRB exempt. We found a total of 1,087 patients who were sterilized in this time period. There was a 106.2% increase in procedures from the year preceding Dobbs to the year following Dobbs. We also found that the proportion of sterilizations increased from 4.6% to 8.1%. Patients were younger. In the 6 years prior to the Dobbs decision, 23.6% of patients receiving sterilizations were in the lowest age group, which was 20 to 29. That increased to 35% of patients being in this age group post-Dobbs. As you can see in the graph on the right, percent of sterilizations that were on patients who were G0 or P0 increased. Nolly-gravid patients increased from 23% to 54% post-Dobbs, and Nolly-Paris patients increased from 28% to 60.4% post-Dobbs. In conclusion, sterilizations for pregnancy-capable people increased at a single hospital in Wisconsin after the Dobbs decision, especially among younger and Nolly-gravid Nolly-Paris patients. At this time, more studies are needed to compare possible changes in sterilization trends in Wisconsin to other states where abortions are legal. Thank you. Please direct any questions to Dr. Laura Hanks or Dr. Jeanette Larson, or you can shoot me an email.
I'm not sure where the other slide went, but it fell out. They're running away. It's fine. Laura, I had a question. So it seems to me that you used for the denominator, like gynecologic procedures. Did you use all gynecologic procedures, minor gynecologic procedures, benign gynecologic procedures? Like what was the criteria?
So interesting. We're like chatting about it. I got distracted.
Hello, my name is Camille Phillips. I'm a medical student at
Hello.
UW-SPH. My co-authors are Dr.
No, I was thinking that too.
You're asking a lot.
You're doing great, buddy.
There it is.
Oh, it's pretty, isn't it?
Okay.
So we used all gynecologic procedures at Meritor. So there were like a couple gynonc in there, but for the most part, it was just like at Meritor, and it was majors and minors. So,
yes. I've got lots of questions. Okay, I'm going to go to Dr. Hartmacher.
Okay. Yeah. I'll just start with obviously great work, and how soon are you going to get this published? Because I think it just needs to get out there. And my only comment is I don't think it's going to be a big part of this, but there has been an increased trend in bilateral salpingectomy for ovarian cancer risk reduction. So you making sure that you at least comment on that so that your reviewer doesn't point it out.
Sure. So to your first question, we submitted to the District 6, ACOG District 6 meeting in Omaha. And so we just submitted that like last week. So we're waiting to hear from that. And then Camille's working on writing paper and going from there. And then to your second question, so retrospective chart reviews at Meritor are really hard. I've found out. So basically what she had to do, despite trying to like work with the Epic people to pull the charts, she went through every single OR day during this time period and looked herself for the surgeries. And she actually ended up going through twice to make sure that she didn't miss any, like just looking at bilateral salpingectomies versus like full curation and whatnot. When she went through the second time, there weren't that many, like it was actually interesting that a lot of we were already doing bilateral salpingectomies as early as 2016. I'm not sure the reasoning, because I think it wasn't it 2018 that ACOG. Yes, we'll say that. we didn't like specify that. It's a good point, like who was getting which one, because we were just trying to do this kind of quickly and just do sterilizations. So yeah, I mean, that would be another idea to look through and kind of like look at. Yes. Yeah. Absolutely. Yeah. Mm-hmm.
So I had the same, obviously, as a REI, the big trend in self-injectomy. And if more women who are younger are going to have self-injectomies, then now they have only one choice if they have regret, which, as we know, is very high as the younger they get. And I see patients regretting and coming in for tubal anastomosis all the time. And my biggest fear here is what's going to happen as women take this choice at that point in time and then later regret it. So it's a balance. And is there an age cutoff that makes it like, okay, if you're older than this, you will have self-injectomy based on regret levels? As we know, that's been published nationally before all this. Younger than 28 have a very, very high risk of regret, and older than 28, not so much, but that still doesn't protect them. I have had patients who had the tubal sterilizations done at 35 and over, and then come at 40 because they have a new partner. That's one thing, it's not directly related to your research, but something I want to bring to the attention of this group as we think about what we offer for patients as a permanent sterilization method. The other question is sort of interesting. I see that a priori you decided less than 0.001 as the significance level, which is very interesting because usually it is 0.05, and then you find out that it is much higher than that. So I was just curious how you came up with that a priori a very, very high significance level.
Right. So to your first question, we've talked a lot about that. And what I think is really interesting is that, yes, kind of traditionally the risk of regret is higher in women less than 30. However, women that are nulliparous, it's not the risk of regret. They are kind of more contemporary studies are showing that the risk of regret is not quite as high in the younger population. So that's why I think it's really interesting that in our patient population, the nulliparous patients population is much higher. So I think that is kind of the next step, is looking at these patients in the next couple of years from your standpoint, who's coming in and who's having regret from this decision. Is it the patients that were younger that have had children or not? I think that's going to be what's really important to look at is making that distinction, not just younger, but have they had children or not? So, and to your second question, I don't have anything smart to say about statistics, but I wish Amy was here because, I was also surprised that it was such a, the p-value was so low, but I don't have anything else smart to say. I don't know if anyone else does.
Laura, I'm going to ask another question since we've got a little bit of time. Do you think these trends, unfortunately, this essential healthcare service has been politicized? Do you think these trends are unique to Meriter Hospital in Madison in Dane County? And if we went to a different county, right? So that's my question. Like, if we compared these trends to other counties or other parts of Wisconsin, do you think it's the same, different?
So you're just saying in our county? That's a great question. I would hypothesize no. I think that a lot of people in our state, or pregnancy capable people in our state, are scared. Not even that. I think that, again, anecdotally, and I think we can all say that we, especially right after the Dobbs decision, had a lot of people coming in really scared. And I, talking to their partners too, also like seeing a lot of partners that are like, yeah, I had a vasectomy, but I'm, she also wants to be sterilized in case. And I think the most heartbreaking is when people talk about, worried about sexual assault. Like, they might be in a monogamous relationship, but they've had a history of sexual assault. And they're like, even though my partner is sterilized, I want to be sterilized also. But, I think that Madison is, in general, we're a more liberal place in the state. And I think people are kind of more aware of these events. So maybe in the more rural areas, it might not be as drastic as this. I mean, that's like, but I do think the trends would be upward. And Camille kind of alluded to in our last slide, we've been working with Dr. Cutler and Dr. Kelly, looking at comparing this with
Yale and what's happening there. They're also looking at it, and it'd be really interesting, to do side by side in a red and a blue state, kind of expanding on your conversation or question. But I think that would be kind of the next step, to look around the county. Different counties would be really interesting too.
So this was happening in Milwaukee too, so I don't think it's isolated to Madison, but I think it's interesting, and I don't know how you would look at this when you have potentially some areas where the care probably wouldn't even be offered due to like the types of like affiliation of the centers. And I don't even know how you would look at that. Like if the only hospital is a religious affiliated hospital that doesn't offer it, if someone is smarter than me, can research.
So one idea you could think about is the Wisconsin Health Association. They have billable codes, and the data to get from them is pretty cheap. And I've recently learned they also have QI, like support initiative, like programs. So I can give somebody the contact information I have, but it might be interesting to contact them because you can get statewide data then on sterilizations, and even maybe look at like rural, urban, or access to care issues.
Great idea, Dr. Hoppy. I love it.
I really appreciate this topic, and it's a fabulous analysis. And I also wanted to say, for both this analysis and for all the students, I have found research briefs to be really great. All journals, or many journals in our field, offer like a 500-word research brief. It's essentially an extended abstract, and especially for more descriptive analyses like this, it's a really good format. It's quick. The review time is quick. And I've learned from journal editors that the acceptance rates are higher because they have fewer submissions. So just a tip I wanted to offer to the students. I was curious, this is so fascinating, and yet contraception, this is one contraceptive tool in a deep toolbox, right? And so I was wondering if what your hypotheses might be. Clearly, you can't get it easily from the Meritor data around, are these people who would be using IUDs but are tipped into getting tubals? Are these people whose partners don't want to get vasectomies? Are these people who were using nothing? Like, I'm just curious, in some ways if we could wave our magic wand, we'd look at trends across all methods, including vasectomy at the same time. And I'd love your thoughts on that.
Yeah, and I think that would then you'd have to look at the UW, look at the when they came in for the initial consult and see, what that conversation was like. I know that I personally, I'm not always the best documented, but when these conversations, I really tried to document like reasoning when people came in, like what were they thinking, what were they worried about, what were they, using before, why didn't they want to use something else? But I have had that thought too. It would have been really interesting if we had done more of like surveys and stuff at the time of that consult. But I think that you could look back at the charts at the initial consultation for sure. Would be really interesting.
And in fact, we have those charts because just before this project, we actually did pull from UW Health Epic charts for sterilization consult. And we have an abstract that's going to be presented as a poster at SFP this fall that's showing a similar trend. But we only looked at like trend of demand by the number of these consultations that were happening 2016 through 2022. But we could do a chart review. We have all of them identified and try and see, what topics or themes came out of the discussions that were documented. Obviously, there are huge limitations to that, but for anyone who's interested in taking it the next step.
Can you all hear us on the remote?
Yes, we can hear you, Dr. Gaston.
I was going to say, did you see any educational racial differences in this? And also, I know I haven't heard anything about men in terms of were there any trends increasing vasectomy amongst men.
So yeah, we looked at race and ethnicity, and it pretty much stayed the same in terms of like they followed the trends. We didn't look at education per se, just because that would have been a little bit more difficult. But as far as men increasing vasectomies, there's a couple studies similar to this that are coming out, not in I haven't seen anything from Wisconsin specifically, but from other institutions, they were also increasing.
Okay, and we are at time. We want to thank everybody for coming. Thank you to our students for their great work and stellar presentations today. Let's give a round of applause. And then to our mentors for volunteering and working with the students. And thank you to all of you for your insightful questions and your attention. And thank you to Dr. Pennycuff for his incredible MC skills.
And thank you to Dr. Jacques for hers as well.